Hi, dear students. Our today lecture is neonatal jaundice, and neonatal jaundice is a common problem during neonatology. It occurs in 60% of the full-term infant and 80% of the premature infants. And it's a yellowish discoloration of the skin and the mucous membrane. It appears clinically in the newborn period when the total serum bilirubin reaches about 5 milligram per deciliter, and this differs in adult, in which clinically the jaundice will appear in adult when the serum bilirubin is more than 2 milligram per deciliter. Here we should look carefully to the pathway of the metabolism of bilirubin, and we should know how the bilirubin is transferred in the blood and how is stored in the liver, getting conjugated, and the pathway of excretion in the intestine. In the bloodstream, when the RBC hemolyzed, there will be formation of heme, and under the enzyme heme oxygenase, heme will be converted to biliverdin. Then the biliverdin is converted to bilirubin under the effect of the biliverdin reductase. If the bilirubin, which is now is indirect bilirubin, it is lipid soluble, it should bound to albumin in the serum to be carried out to the liver. If the bilirubin, indirect bilirubin, remain free in the serum, this is dangerous. It poses dangerous effects on the neonate and might cross the blood-brain barrier. So any drugs that compete with the bilirubin binding site to albumin might increase the indirect free serum bilirubin, which may cause kernicterus. After bounding to albumin, they enter the liver and will be uptaked by the liver, and then under the effect of glucuronide transferase enzyme will be conjugated into direct bilirubin, which is secreted in the bowel, and will be converted into fecal bilirubin and urobilinogen. Here, under the effect of glucuronidase enzyme that is present in the intestine, some of the conjugated bilirubin will be deconjugated into indirect bilirubin and go through enteropathic circulation. So we should put in mind any intestinal obstruction like meconium ileus or atresia or whatever the cause of intestinal obstruction will increase the effect of the beta glucuronidase and will increase the enterohepatic circulation, where هيزيدن البيليروبين level indirect, ممكن increase the risk of kernicterus also. So here the factors that increase the level of indirect bilirubin in the neonate that we just mentioned: any hemolytic disease like RH and isoimmunization, any compound or drugs that compete with the bilirubin binding sites, methylmagne to albumin, like the sulfa drugs and vitamin K, decrease in the concentration of glucuronide transferase enzyme in the preterm infant and in cases of hypoglycemia, and any conditions that increase the enterohepatic circulation. The causes of indirect bilirubinemia, one of the example and the commonest example of indirect hyperbilirubinemia is the physiological jaundice. Physiological jaundice, it is common in the neonate, in the preterm and the full-term infant, and the theories behind its causation is the large RBC mass. الحقيقة large RBC mass هي تكونت in utero because of the hypoxic environment. So the infant will respond to this hypoxic environment by stimulation of the bone marrow and increasing the RBC mass. After delivery, the newborn baby does not need this large mass of RBC, so there will be destruction of the excess RBC and will release bilirubin, while causing physiological jaundice. Another theory is the defective hepatic uptake of bilirubin from the blood, and the third theory behind its causation is the defective bilirubin conjugation due to immaturity of the glucuronide transferase enzyme. What are the criteria of the physiological jaundice? The type of the bilirubin is huge and is mostly indirect. If it is direct, it is not physiological jaundice. And the onset of presentation will be from the second day of life, not from the first day of life, so it is physiological. The baby looks healthy, feeding well and non-organomegaly, and rarely require phototherapy. ومرة نشوف هنا احنا نلاحظ ذول اللي هم على البريست فيدنج البيليروبين level slightly higher than other breastfed infant. The peak of the jaundice does not reach more than 12 milligram per deciliter on the 5th day of life and 15 milligram per deciliter بالpreterm baby. وبعدين طبعا هذا راح يصير decline over the last 7 to 10 days and it disappears spontaneously. So it is a benign condition. What are the criteria of the pathological jaundice? Any of the following features that if present we regard this jaundice as pathological, like clinical jaundice appearing in the first 24 hours, the rate of the increment of the serum bilirubin was high, like 0.5 milligram per deciliter per hour, especially in the first day, or 5 milligram per deciliter per 24 hours. If the peak bilirubin more than 13 milligram per deciliter in an infant, ما نعتبر physiological. Direct bilirubin more than 1.5 milligram or 20%. Direct bilirubin إذا كان 20% of the total serum bilirubin, we regard this as non-physiological jaundice or pathological jaundice. And lastly, if there is hepatosplenomegaly present. The causes of pathological jaundice either from increased production of bilirubin, like in hemolysis, feto-maternal hemolysis, or spherocytosis, or enzyme defects, and increase interhepatic circulation, like in pyloric stenosis or intestinal obstruction or septicemia. And on the other hand, there may be decreased clearance of the bilirubin, like in Crigler-Najjar syndrome, in which there is a permanent deficiency of the enzyme, glucuronidase enzyme. Drugs and hormone like hypothyroidism, ونعرف احنا الthyroxine is a stimulator of the glucuronidase enzyme that is responsible for conjugation of bilirubin. Also, breast milk jaundice. What are the intrinsic causes of hemolysis? We take an example of them, like membrane defects, spherocytosis or leptocytosis, or systemic conditions like sepsis, and maybe enzyme deficiencies. Well, the extrinsic causes is the ABO and RH immunization. We take an example of non-hemolytic causes of jaundice, like a big cephalohematoma, which is, as we mentioned, in the birth injury. It is a large subperiosteal hemorrhage, and this blood will be lysed and releasing bilirubin. Polycythemia also is another risk factor. Sepsis, hypothyroidism, Gilbert syndrome, defect in the uptake of bilirubin, and Crigler-Najjar syndrome. What are the criteria of the conjugated bilirubin or the hepatic causes? Here, clinically, the color of the infant will be yellow to green huey color. And when you ask in the history, the mother may say that he passed a dark urine because of the presence of the bile pigment and pale stool. And the causes of the hepatic jaundice mostly in the form of infections, which is sepsis or hepatitis B that may be acquired from the mother, torch infections also causing hepatitis and jaundice, metabolic conditions like galactosemia, defect in the galactose absorption, alpha-1 antitrypsin deficiency, and cystic fibrosis. And there may be idiopathic causes. Also, there may be obstructive post-hepatic, we call it, like in biliary atresia, and there are two forms of biliary atresia, intrahepatic and extrahepatic biliary atresia, and choledochal cyst, which is a large congenital cyst of the bile canaliculi that compress on the bile canaliculi, causing jaundice, obstructive jaundice. How we investigate a patient with jaundice? When we see a neonate with jaundice, after taking a proper history of the blood group of the mother and the RH of the mother, and history of previous neonate with jaundice and hyperbilirubinemia, history of exchange transfusion. Also, we ask the feeding history because we will mention in the next sessions the breast milk jaundice. So the feeding history is also here is important. And if the mother has jaundice or hepatitis, also we should take that in the history. And after that, we do total serum bilirubin with a fractionation into direct and indirect bilirubin. And if we see mainly the bilirubin, hyperbilirubinemia is indirect, we will do complete blood picture to see the hemoglobin level. In case of hemolysis will be low, and reticulocyte count will be high, and also in the blood smear we may see abnormal cells like spherocyte in hereditary spherocytosis. And if there is an RH and ABO incompatibility, we send the newborn Coombs test, which is positive in RH and in ABO incompatibility. These are the most common investigations that we may need. And if we suspect, of course, enzyme assay, we should do this. If the case of we suspect G6PD, we may send the enzyme assay after 1 month from the attack of hemolysis. Why we send it after 1 month, not immediately? Because the reticulocytes, which are the immature cells, may contain normal enzyme level. So we should wait for 1 month until the mature RBC grow, and we will send for enzyme level to detect the real enzyme that are present in the RBC. While the investigation of the conjugated hyperbilirubinemia, if we find that the direct bilirubin is 20% of the total serum bilirubin, we regard this hyperbilirubinemia as conjugated. So we may send for liver enzymes, will be elevated in case of hepatitis, bacterial and viral culture if there is septicemia and if there is hepatitis, torch screen if we suspect and stigmata of torch infection, hepatic ultrasound and CT scan to detect choledochal cyst or intrahepatic biliary atresia, metabolic screen as we said in case of galactosemia, sweaty chloride test in case of cystic fibrosis, and if the diagnosis is still obscure in certain glycogen storage disease or another storage disease, we may send for liver biopsy. Now we come to the common entity also of neonatal hyperbilirubinemia is the breast milk jaundice. And the criteria of the breast milk jaundice, it is a form of indirect or unconjugated hyperbilirubinemia without evidence of hemolysis from the second day of life, from the second week of life, started second week of life and may continue up to the 40 days after birth. What are the theories behind the breast milk jaundice? They suggest that there may be inhibitors of the glucuronidase enzyme present in the breast milk, or in the breast milk there is glucuronidase enzyme that we mentioned in the metabolism of bilirubin that is present in the gut. This will cause deconjugation of the bilirubin and will increase the enterohepatic circulation. Anyhow, the bilirubin level does not reach a dangerous level and does not need exchange transfusion. The baby is healthy, growing well, and there is no hepatosplenomegaly or anemia. So all we may done that we interrupt the breastfeeding for 1 to 2 days. We will see that there is a great drop in the level of bilirubin. This hyperbilirubinemia, as we said, may persist for 3 to 4 weeks, and there is no need to stop breastfeeding. Another form of indirect hyperbilirubinemia is the Crigler-Najjar syndrome, which is a permanent deficiency of the enzyme glucuronidase enzyme, inherited either autosomal dominant or recessive, and here we may need phototherapy for a prolonged period of time and may need frequent exchange transfusion. Another form of indirect hyperbilirubinemia is the Gilbert syndrome, which is indirect hyperbilirubinemia due to defect in the hepatic uptake of conjugated bilirubin. Here we put a table of the differential diagnosis of prolonged neonatal jaundice. On the top of the list, breast milk jaundice. So in the history, we should ask about the type of the feeding, whether it is bottle or breast. Number 2, sepsis, biliary atresia, hepatitis, torch infection, galactosemia, hypothyroidism, congenital spherocytosis, and G6PD deficiency. What are the complications of hyperbilirubinemia? Is what is called the kernicterus or the bilirubin encephalopathy, which is a neurological syndrome resulting from deposition of indirect bilirubin, which is lipid soluble, as we said, crossed the blood-brain barrier and deposited in the basal ganglia, and characterized by early manifestation like lethargy, hypotonia, irritability, weak motor reflex, and poor feeding. So the mother will complain that her newborn infant is lethargic, he's not completing his feed, and when we examine him and we do the primitive reflexes, we will see there is a weak motor reflex. And if we, at this time, we should interfere, we should treat the newborn baby with extensive phototherapy to prevent further damage, because the late manifestations that may occur after the first week include obstetronic posture with neck retractions and hypertonia, and of course with seizure also. By the end of the first year, the newborn baby will be crippled. There is a choriothetoid cerebral palsy, developmental delay, mental retardation. And here the photo of the infant with hyperbilirubinemia and kernicterus. You see the neck retraction backward and the spastic position and the yellowish discoloration of the newborn. And as we said, the free indirect bilirubin here is the more dangerous, not bound to albumin. This will cross the blood-brain barrier because of its lipid solubility, or maybe because of disruption of blood-brain barrier under certain pathological conditions like asphyxia, acidosis, sepsis. So in these conditions will disrupt the blood-brain barrier and will facilitate the deposition of the indirect bilirubin in the basal ganglia. Then, when there is risk factor like septicemia, acidosis, hypoglycemia, and hypothermia, this will increase the risk of kernicterus even at lower serum bilirubin level. So, in the full-term infant, the kernicterus usually does not occur below 20 ملغ per deciliter. ممكن فوق يعني without risk factor طبعا يصير after 20-25 ملغ per deciliter. والprevention هو by early initiation of phototherapy or exchange transfusion to treat the above risk factors. Now we come to the treatment of hyperbilirubinemia. Classical treatment of hyperbilirubinemia is the phototherapy, and we have the traditional phototherapy and the extensive phototherapy. And the extensive phototherapy, we use it when there is a dangerous bilirubin level approaching the 18 or 19 or 20 mg per deciliter. We can put the infant in the extensive phototherapy. It's a form of lights that will be cover all the skin of the newborn baby from all directions, and we put the baby in this device naked, just with his eyes closed to avoid phototoxicity. We can put this infant for a few hours, and then if there is a drop the serum bilirubin level, we can put him under the traditional phototherapy to avoid heat exhaustion. We use the blue or white light, 425-475 nanometer wavelength, and it is indicated phototherapy in the newborn infant. The full-term infant without risk factor, we may need it 16 to 18 mg per deciliter, and of course lower level preterm babies to avoid the kernicterus, 12 to 15 mg per deciliter. The newborn eyes should be covered to avoid light toxicity. Well, of course, the traditional phototherapy, traditional, not the extensive, need 6 to 12 hours to have a measurable effect and reduce the serum bilirubin level by 1 to 3 mg per deciliter per 12 to 24 hours. The newborn under the traditional phototherapy should be put under 15 to 20 centimeter from the fluorescent lamp. What are the complications of phototherapy؟ طبعا هاي مهمة وهواية يمكن ننسأل عليها. First of all, because of the excessive heat, there will be increase in the insensible water loss and dehydration, diarrhea with a green stool because of the effect of the phototherapy and light on the GIT, maculopapular skin rash, lethargy because of heat exhaustion, risk of retinal damage if we didn't cover the eyes of the neonate, and the skin may turn bronze color if the newborn have a direct hyperbilirubinemia. The second method of treating neonatal jaundice is the exchange transfusion, and this is indicated when there is a high dangerous level of bilirubin, as we said, and the extensive phototherapy didn't resolve the problem, or the newborn baby has a high serum bilirubin level, we may say 25 milligram per deciliter, so we should prepare for exchange transfusion. And here the role of the exchange transfusion in treating hyperbilirubinemia, it will act by removing 90% of the sensitized RBC in cases of RH isoimmunization and ABO immunization, ABO incompatibility, before they are hemolyzed, and also remove about 50% of the bilirubin from the plasma. So it will reduce the serum bilirubin by this method. It is indicated in a full-term infant in the level of 20 milligram without evidence of hemolysis, or 25 milligram. I mean 20 milligram with evidence of hemolysis and 25 milligram without evidence of hemolysis. or risk factors إذا كان الويت of the baby is good and more than 2000 gram. In a preterm baby, we use the role of 1% of the body weight in a gram, 1% of the body weight in a gram, in calculation of the, or in assessing the need for exchange transfusion. For example, if the weight of the baby 1500 gram, the exchange level is 15 milligram per deciliter. And when the newborn baby, for example, 1200 gram, the exchange level is 12 milligram per deciliter. And of course, it is done in a lower level than these when there is risk factors like septicemia, like acidosis, like hypoxia, and any risk factors. The blood prepared for exchange transfusion should be whole blood and fresh, and should be aspirated within 3 days, and it's cross-matched with the mother of the baby. The total amount of the blood exchange should be calculated by using the following formula. The amount of the blood equals to the infant weight in kg multiplied by 100, which is the volume of the blood, by 2, multiplied by 2. So we are using double the baby blood volume. The blood volume of the neonate is around 100 ml per kg. So we are using double the baby blood volume. Infant weight in kg plus 100 plus 2. Why we use double baby blood volume? To exchange more of the sensitized RBC and to get rid more of the indirect toxic bilirubin. In each cycle, we aspirate 10 to 20 ml of the blood from the infant and infused per cycle, and the whole process is last about 45 to 90 minutes. For each 100 of blood exchange, we give 1 ml of calcium gluconate, and the exchange transfusion is done through the umbilical venous catheter. This is the exchange transfusion set that we are using in the neonatal care unit. And this is the valves that we need in doing the exchange transfusion. And this is the schematic presentation of how we do the process. By turning the valve toward the umbilical cord, we aspirate 10 to 20 ml. If the health status or cardiorespiratory status of the newborn baby is good and the weight is good, we can aspirate 20 ml per each cycle. And if the baby weight is small, or a preterm baby, or a presence of risk factor, we can aspirate 10 ml per each cycle. So first step, we aspirate 20 ml of blood from the newborn baby, and then we turn the valve toward the waste bag. We throw the blood of the neonate in the waste bag, and then we turn the valve toward the fresh blood. We aspirate 20 ml, and then we inject it to the newborn baby. Here we finish just one cycle. We push 20, we aspirate 20, and we push 20 ml. Then we will also, again, the second cycle, we aspirate 20 ml from the newborn baby, we throw it in the bag, and we aspirate 20 ml of fresh blood, and we inject it to the umbilical cord إلى newborn baby umbilical cord catheter. This is the second cycle. When we reach 5 cycles, I mean 100 ml, we aspirate and inject. We should give 1 ml calcium. Okay, we continue with this process. We aspirate 20 ml and we give 20 ml of fresh blood until we reach the total amount of the blood that we just calculated in the previous slides, اللي هو قلنا عليه double the baby blood volume. How much we calculated, we stop. If we calculate 330 ml, for example, when we reach the 330 ml by aspiration and injection of blood, we should stop at that time when we reach the calculated amount. What are the complications of exchange transfusion? First of all is the transfusion reaction because of blood group incompatibility, hyperkalemia if we use an all the blood in the exchange transfusion, hypocalcemia, infection like sepsis from catheterization if we do it in non-sterile technique, or blood-borne infection like hepatitis, vessel perforation, mechanical trauma, hemorrhage or thrombosis, hypotension, and necrotizing enterocolitis. Another form of treating neonatal bilirubin, lastly, they use the intravenous immunoglobulin to interfere with the immune-mediated clearance of the antibody-sensitized RBC. And the yearly administration of intravenous immunoglobulin may be effective therapeutic intervention. So it will prevent the immune hemolysis, it lower the peak serum bilirubin level, and shorten the duration of phototherapy. It reduces both the length of hospitalization and the need for exchange transfusion, but also there is a drawback of this process. It does not correct anemia. It may reduce the hemolysis and may reduce the bilirubin level, but it may, and here we may need a blood transfusion in case of anemia. The dose of the intravenous immunoglobulin is 0.5 to 1 gram per kg, and the treated infant with blood group A or B should be monitored for worsening hemolysis caused by anti-A or anti-B antibodies present in the immunoglobulin. Now we come to another subject or cause, important cause of hemolysis is the RH isoimmunization. And the RH isoimmunization, the mother is usually RH negative and the baby is RH positive. And the RH antigenes, common RH antigenes is the capital C, capital D, capital E, and small c and small e. Here the mother, as we said, the RH negative blood group and the baby RH positive. When small quantities of blood from the neonate enters the maternal circulation as 30 ml, which is an RH positive fetal blood cells, enter the maternal circulation. When it enter the maternal circulation during labor or abortion. So the first baby is usually not affected in RH isoimmunization. Why? Because the sensitization will occur at the time of the delivery. In rare conditions, the sensitization may occur intrauterine when there is manipulation to the neonate, what we call the antiversion of the neonate, or any procedure done to the neonate intrauterine may cause the reaction, and these are rare conditions. So these maternal antibodies will readily cross the placenta in the next pregnancy. In the next pregnancy, the mother here is sensitized, and in the second pregnancy, these, and if the baby blood group are RH positive, these maternal antibodies will readily cross the placenta and causing hemolytic disease of the newborn. When the mother and her baby are incompatible with respect to the A or B blood group, for example, if the mother A negative and the baby B positive, there is a lower chance of maternal sensitization because of the rapid clearance of the fetal cells by the mother anti-A or anti-B antibodies, which are IgM that does not cross the placenta. We should know that the tendency for the severity of the RH isoimmunization to worsen with the successive pregnancies. كلما تقدمت الأمين بالبريجنسيز الحمل الأول الثاني الثالث الرابع وهكذا there is increase. طبعا إذا ما ماخذة هي الأنتي دي جلوبولين there will be increase in the severity of the RH disease with the successive pregnancies. And regarding the clinical presentation, may be presented with severe presentation like hydrops fetalis, in which there is a severe sensitization and severe hemolysis causing heart failure. And hypoglycemia also may occur due to hyperinsulinism here. And the second common presentation is the moderate sensitization. Here the baby born with pallor, jaundice in the first few hours of birth, and hepatosplenomegaly. And the third one, if there is a mild sensitization, there will be mild hemolysis and mild jaundice with anemia that may require only a blood transfusion. What are the necessary laboratory investigation in RH isoimmunization? First of all, we should do ABO and RH blood group of the mother and the baby to see the what's going on. As we said, complete blood count to see the hemoglobin level, the reticulocyte count, and the shape of the RBC. And the direct Coombs test, of course, will be positive. Anemia, there will be anemia with complete blood picture. And the cord bilirubin may reach 3 to 5 milligram per deciliter and may rise rapidly thereafter. The antenatal diagnosis and the management, this is the gynecological concern. And the treatment of the live-born infant with RH disease, how we approach to the management of neonate with RH isoimmunization. First of all, we should, after we did the investigation that we just mentioned, we should prefer fresh whole blood. And if we are in an emergency condition and we need to do urgent blood transfusion, exchange transfusion, we request O negative blood group and should be compatible with the newborn and his mother, or we may choose the blood group of the baby and the RH of the mother. Here, the type of blood to be exchanged, we can choose the blood group of the baby and the RH of the mother. So, if the baby blood group B positive and the mother is B negative, for example, or A negative, we use B negative blood group. We are using the blood group of the baby and the RH of the mother to avoid further hemolysis. And monitoring of the serum bilirubin, we put the neonate under extensive phototherapy until the blood is prepared and cross-matched. And there are certain indications for immediate exchange transfusion after delivery of the newborn baby. If the cord hemoglobin 10 gram per deciliter, if the cord bilirubin 5 milligram per deciliter, or if there is high reticulocyte count, we do immediate exchange transfusion. And you know the prevention of the RH isoimmunization by giving human anti-D-globulin to the RH negative mother within 72 hours after delivery, or abortion in a dose of 30 microgram, which equal to 1 ml, to prevent the sensitization. On the other hand, the ABO incompatibility is also a common cause of jaundice in the first day of life, hemolytic jaundice. Here usually the mother is blood group O and the newborn baby is the blood group A or B. And we know the mothers with the blood group A or B, sensitization will not occur because they have already IgM antibodies which does not cross the placenta. Because many mothers with blood group O already have IgG antibodies against the A or B blood group before pregnancy, so the firstborn infant will be affected. And here the condition differs, not like in RH isoimmunization. We said in RH isoimmunization the first newborn baby is spared, not affected. And here in ABO incompatibility, the first born infant will be affected and will be presented with jaundice in the first day of life. Hydrops fetalis is extremely rare, and overall the hemolysis in ABO incompatibility is less severe. and the severity of the ABO incompatibility decline with the successive pregnancies, not like in RH isoimmunization. The investigations that we use is the direct Coombs test is weakly positive, also complete blood count on the RH antibody group of the mother and baby. Blood smear will show spherocyte and increase in the indirect bilirubin level. Hemoglobin may be normal or low. Reticulocyte count is increased, and the treatment is also by phototherapy, either traditional or extensive phototherapy, a blood transfusion, or we can use the intravenous immunoglobulin.